All right. I have Dr. Max with AlphaGenix UK tuned in today. Hey, Dr. Max, how you doing, sir?
Hi, Justin. Yeah, brilliant. Thanks for having me.
Yes, sir. Thank you for spending some time with us today. Would you mind giving us an introduction, who you are, a little bit about yourself, what you do, and what AlphaGenix is all about?
I'm Dr. Max Draper. I am the lead clinician or physician with AlphaGenix, which is a UK-based men's health TRT clinic. I was formerly trained as a GP, so I was a family doctor for best part of 10 years. And it was through my own experience with low testosterone that basically drove me to learn more about the subject and the topic and basically end up inspiring me to eventually leave general practice to do this kind of work full time. AlphaGenix, what we do is mainly TRT, but there is an element of sort of longevity and lifestyle medicine to it as well. So we kind of look at it as
Sure.
the whole picture, really. Yeah.
Gotcha. Right on, man. Right on. So, how did your personal experience with TRT, how that lead you into this path? Like, how what was that trajectory leaving, primary practice into specialized practice?
Yeah, so I was my story began with I had testicular cancer at the age of 29.
Oh,
So
damn, dude.
yeah, well, compared to low testosterone, I always say it wasn't really that bad. I mean, so at 29, I was diagnosed. I had my left testicle removed. And now looking back, I could say probably about 6 months after surgery, a year, I probably noticed some symptoms, hindsight being 2020. But then I started getting ill quite often. And that culminated with viral meningitis about 2 years post-surgery. And after viral meningitis, I was just ruined. And I was
Sure.
ruined. I was lived in a really bad place for about 2.5 years, I would say, until my level of testosterone was, like 200-ish in your units. And that was deemed appropriate for treatment at that point. And within weeks of starting even the gels, my life was like so much better. And so that was about 4 years ago, I think now. And so just prior to starting treatment and following the life-changing effects of treatment, that just inspired me to basically spend a hell of a lot of time going through, you know, the details about how testosterone affects men, the benefits of TRT, but also lifestyle medicine, all of that stuff as well. So basically for the last 3, 4 years, I've been pretty obsessive about learning more about these topics, really. And
Yeah,
then it
yeah.
wasn't until, and I basically fell out of love with general practice, particularly over, maybe it was inspired more so by the pandemic and everything like that. But I just loved this work. So I was already doing it part time at that point. About a year ago, I decided to fully stop general practice and
Yeah.
fully enter this world, really. And it's been a decision I haven't really looked back at, to be honest.
So, what's the education like in terms of how the education system in the UK in terms of men's health, hormone replacement? Or is that something you had to do on your own, or how did you learn that?
Yeah, it was 100. It was 100% self education, I would say. I think when I was a GP, before learning about this, I probably knew low testosterone could cause erection issues.
Sure.
Um, Other than that, I don't think I knew anything or very little about it. So I can't remember getting any lectures or information about testosterone or men's health in general as a topic at med school or during general practice training. So yeah, it has been pretty much self-education, really. I always say I was really fortunate because when I started learning about this, it was shortly after the TRT hormone optimization channel was made.
Yeah,
You've
yeah.
been on there as well yourself, and so I ended up, watching a lot of that videos, and then that would sort of point me down the line of reading these papers, reading this research, and I ended up reading about 10 books. People like,
Oh,
Dr. Andrew Wingy's book and Jay Campbell and all of these classic books in this space, so it was really self-directed learning. And I just developed a real passion for it, to be honest. Even things like shbg, that's actually quite an interesting topic to me
sure, for sure.
when you start reading about these things. Yeah, so it's all completely
That
self-education, I would say.
I mean, that's how it is here in the U.S. We didn't. virtually no lectures. Even when it come to learn about thyroid, all they taught us was TSH, follow the TSH. If it goes up, put them on meds. That's it. That is the extent
Mhm.
of our
Yeah,
thyroid lectures. We didn't learn anything about testosterone. So
yeah,
I'm right there with you, man.
yeah. And it's all
How
with the thyroid. It's T4 alone. No one needs T3. Yeah,
Yep.
it's all very much standardized. Yeah,
So I mean, y'all's system is pretty similar then. I'm guessing it was
yeah,
just the basic.
yeah. I
Gotcha.
would think so. Yeah, exactly. And testosterone, like certainly testosterone replacement was never touched upon really. Yeah.
No, no. Interesting that you mentioned SHBG. Has there been any new nuances of SHBG you've learned about? Because a lot of people just think, free or not free, we just use a Vermilion formula. That's what a lot of people think the SHBG is pretty much for, to calculate the free. Any new research that you've seen come out on it?
I just think with SHBG, it's kind of like you can overfixate on it or you can
Oh, for
underfixate on it.
sure.
I certainly think it's not all about free testosterone. And I
Sure.
think, SHBG bound testosterone, I think saying it's completely inactive is probably a mistake. Having said that, I think guys with a high SHBG and a low free T can feel like rubbish, but sometimes they can seemingly function fine.
Hmm.
Um, I just think there's a lot of individuality to it that we don't fully understand. Um, and it probably does vary even from guy to guy how much it impacts, how much that free testosterone is the significant marker, or is it a combination of the two? Because some guys will have a great total testosterone and have a low free T and they'll feel like rubbish. Some guys will have exactly the same picture and feel fine. So we
Yeah.
don't I don't think we fully understand even to this day. I think there was a recent paper, I think it was saying that the driving force of low SHBG seems to be inflammation, which kind of makes sense when you see a lot of the
Oh, no doubt.
guys with low SHBGs. But yeah, it's an interesting. I don't think it's fully understood though, to be honest. And I think like Jordan Grant said on your interview with him recently, he said about how you've just got to, symptoms is so much the driving force rather than over fixating on a lot of the labs,
Yeah,
really.
for
And
sure.
I would agree with that largely for sure.
What do you think some of the things that they spend too much time worrying about? Because we get these patients, they may feel great, but then they just start, like you said, they hyperfixate on little stuff that really doesn't matter. How would you coach them through that?
Well, the classic worries are, what would be the classics? Would be like a mildly elevated prolactin on TRT, an
Oh yeah,
elevate an elevated estradiol on TRT, or like an elevated hematocrit on TRT if it's driven by testosterone. I think those tend to be the classically worrying blood results that you or I we would be like, yeah, this is kind of expected on
yeah,
testosterone. You don't
yeah.
need to overly fixate on it, but probably the most common one is I always say to guys, I get asked about estradiol every day,
Oh yeah,
probably, probably at least once a day, but often 2, 3 times a day. And it's always because it comes back as raised on the lab results. And we do a our labs are kind of a standard bundle of labs, so we have to check estradiol in essence, basically. So I've
sure.
seen I've seen hundreds and hundreds of estradiol results, and so I'm quite well placed to say to them, look, I don't worry about the estradiol result, man. So neither should you. So yeah, probably those are the biggest patient worries, I think. Just slightly abnormal blood results on paper, which don't really mean too much to us in practice.
It really doesn't, man. And you hit the nail on the head. Like we expect these things to be out of range when you're on these hormones. I mean, it's part of it. It's a anticipated response. There's really nothing to worry about. It's part of the process. Now,
Yeah.
I'm kind of curious. You said you started off with a gel. How's your personal treatment? How's that evolved? Are you still using some kind of transdermals or anything?
I ended up going from the gel to cypionate because I actually joined AlphaGenix as a patient originally.
Yeah,
It was actually because I spoke to one of the owners of the company and I started asking him questions, and he was like, "Have you ever considered doing this job?" Because I was asking him loads of questions because I'd already learned quite a lot by this point. So yeah, I rolled on to injectable cypionate, and I actually inject daily or alternate days if I'm on holiday or something like that, and I just don't want to
sure.
travel with as many needles. I don't need, I wouldn't say I need to inject daily, but it was just the way I started. So I've never really felt the need to change it. If I went back, because this is a few years ago now, if I went back before going on injectable cypionate, I probably, given the fact I'm doing daily, would have gone for the cream. I probably, in hindsight, I probably would have gone for the trans-scrotal, compounded cream, I think. And I may one day switch just to try it out. Yeah.
Do you have a lot of guys that are on the transdermal?
Yeah, fair few. Probably maybe like 10, 15% of patients are probably on
Hmm.
the cream, maybe, I would guess. Yeah. Most are on on cypionate, either subcut or IM. Most are. Yeah. Depending on
Sure.
what method they get on with best, really.
Right on, right on. So as a clinician, from your perspective, do you see any small nuances or tangible differences in how people report how they feel, how they respond when doing injections versus transdermals? Do you see any difference really?
Not massively. I mean, maybe anecdotally, I mean, maybe the guys on the cream feel a bit mentally better, quicker, if you see what I mean. And then maybe cypionate more physically better, but it does vary. I mean, there's not enough to discern to say one is
Sure.
better for this, one is better for the other. I just found anecdotally that the cream tends to clear up the mental side, the mental symptoms of low T, maybe a little bit faster, but everyone's a little bit different, I guess.
Yeah, yeah. Do you have any speculation as to why that may occur that way?
Well, with the cream, I suspect you get, and I've heard Dr. Nichols talk about this on his podcast as well, about how you get a higher level of free testosterone compared to the total on the cream, and it's because the DHT binds up some of that shbg, so you
Yeah.
get a little bit more free. So maybe there's an element to that. I suppose just that potentially each day on the cream, you're getting this peak and a slight diurnal rhythm maybe to it. But yeah, I'm not 100% sure. Maybe it is a little bit more free T, impacts us cognitively, a bit quicker, maybe perhaps. Yeah.
It's interesting you
What
mentioned
do
that
you-
because when I first started testosterone, one of the first benefits I noticed, it was the mental clarity. I just felt sharper. I felt I could organize my thoughts. I could categorize my thoughts a lot faster.
Oh yeah, 100%. I think brain fog for me, because my symptoms of low testosterone were largely psychological. So there's a lot of like sort of, anxiety, thoughts were just completely disordered, had a lot of brain fog, poor memory in hindsight. That was pretty shoddy. But yeah, and just a general sense of just every day is a struggle. I would say those symptoms improved the fastest, and then sort of I had low energy and fatigue. That took a little bit longer, but yeah, I'd probably say brain fog or clarity is one of the earlier symptoms to improve, for sure. In general, guys. Yeah.
Right on, man. Right on. So you said that AlphaGenix, and you also offer some more longevity type stuff.
Mhm.
What would some of those like services or evaluations include?
Yeah, so we look at things like metformin, daily
Hmm.
Cialis, telmisartan. We can't really, I mean, I've never delved deep into the things like rapamycin, and that seems to be quite, I know guys who are taking it, but
Hmm.
in the UK, it's not really something you could easily get your hands on or prescribe, I wouldn't say. And then the lifestyle stuff. So we've got like a strength and conditioning coach who's
Oh,
also,
awesome.
yeah, he's got a lot of knowledge in the world of nutrition and things like that as well, because you know it's hard to go into all of that when you're dealing with the medical side of it. So he kind of takes over a lot of the coaching aspects of it, because all of that's so significant to living well and living a long good life as well. Yeah.
That's actually pretty awesome that y'all do that because I've seen a lot of guys get on TRT and they say they never feel optimal, but I mean, you're not going to feel optimal until you start integrating those lifestyle enhancements, those lifestyle changes. Testosterone just it doesn't do the work for you. At the end of the day, it doesn't it doesn't. You know, you still have to put in the work. You have to bust your butt to make it work for you.
Yeah, I mean, there's a few things that seem to derail people or make them never see that full, optimized feeling. And I think one of them is regular alcohol. I think a lot of people, I don't know what it's like over there in the States, but a lot of people in the UK have a beer or a couple of beers every day. And it's not an unusual habit to have a drink every night. And I think that doesn't really help optimal health as such and optimal functioning. And then stress. I think who are pretty stressed out. I always think that's going to dampen the effects.
Oh,
And
sure.
I just think it's, you can be on as much testosterone as you like, but if you're stressed out to the hilts and you're not sleeping enough, then I don't think anyone would ever feel optimal in that sort of state. But a lot of people nowadays are really stressed out and
Yeah,
not getting that relaxation time in properly, or at least not prioritizing learning how to manage with stress and actually learning how to just bring your body down a notch.
sure. Absolutely. Absolutely. What are some of the negative consequences of people doing, consuming alcohol regularly? What would you say how that offsets the TRT protocol?
Yeah, I just think what I tell to guys is kind of like, it's the idea of like regularly exercising, getting your sleep in, putting the right stuff in your body. So nutrition and things like that. It's kind of like what I consider alcohol, regularly. And obviously people talk about the effect on enzymes and the liver metabolism and everything. But how I would describe it is you're constantly applying like a degree of stress to the body, because our
Oh,
body, is not naturally designed to be having a constant stream of alcohol intake. So I
sure.
just describe it's kind of like this side of life reduces stress, this side of it increases it, and I put alcohol on this side of the equation. And I just say what we want to do is reduce the stuff that's increasing the stress and use appropriate things to, like exercise, acute stress, but actually long term reduces chronic stress. That's kind
Sure.
of that. And I use that kind of terminology with people just to say, look, if you're stressing your body out every night by giving it what is essentially a poison, then how do you expect to feel tip top every day? It just makes sense when you put it like that.
Absolutely. That's a excellent analogy. It's just like you got this force, and they're kind of just mitigating one another, so to speak.
Yeah, yeah, 100%. I think a big deal as well with people is being active. I think the big difference for me when I changed from being a GP to doing this full time is I've got a lot more um, sort of self-determination of my time. So it's kind of like I will go to the gym each morning before I start work now. Whereas when I was a
Yeah.
GP, I was driving 45 minutes to work and then 45 minutes at the
Ooh.
end of the day. It was just kind of like it just eats away at your time when you're able to be active. So now, even if I don't go to the gym, I'll go for a long walk with my wife and we'll go walk the woods and things like that. So just having that general activity level, I think is really significant. Yeah.
Besides testosterone, do y'all ever evaluate or, treat for other hormone deficiencies or any, so let's say like pregnenolone, like DHEA or things like that?
Yeah, so we routinely monitor thyroid. We don't routinely. We do have an option to monitor DHEA and pregnenolone. The issue with those in the UK is just the blood test alone is expensive. So
Sure.
I tend to more recommend it if people have potential symptoms, but also potential risk factors. So like, or that, conditions where they may benefit from the addition of pregnenolone and DHEA, like traumatic brain injuries or
Yeah.
recurrent concussions, PTSD, that sort of area where you suspect a degree of neuroinflammation, I guess. So not routinely, but I do tend to try and recommend guys getting it checked, either if they've got an obvious potential cause for a deficiency or if they're having symptoms to suggest an issue with them. But the issue genuinely with DHA, I mean, like pregnenolone, just pregnenolone blood test alone is more than, you know, a full normal panel of bloods in
Yeah.
the UK. So I don't know is it that expensive in the US? Is it very costly to check pregnenolone?
Yes, and it can be cost prohibitive. Another thing about
Yeah.
it is the turnaround time on it is usually 1 to 2 weeks. So
Yeah.
it's slow and there's really not much standardization across the board. So you can go to 3 different labs and dude, it's just all over the place. It's no
Yeah.
consistency.
Yeah,
So
I mean, I
it's
think here we don't actually have a normal lower limit for pregnenolone. We
no,
don't know. the lower end of the range should be. So yeah, it's a difficult one. It's a difficult one. Sometimes I'll just suggest guys check them to show their, to make sure they're not in their boots. But I suppose the argument would be you would optimize them even if they were kind of the lower end of the range, particularly if guys had potential symptoms. I've been hit and miss. I have had a few patients who have, added in DHEA and pregnenolone, and it's certainly not as consistent as testosterone in terms of the benefits in terms of symptoms, really, for sure. Some guys find they actually feel worse on them than not. But so I think it's more of a finer art, more of an individual bit of it, like Dr. Jordan was saying, a bit of a trial and error approach to it, really.
Yeah.
I can see the logic to that. I know there's a lot of different varying thoughts on pregnenolone and DHEA in this space. I know, sort of heard Dr. Mark Nichols talking about, is it Mark Nichols, isn't it? I forgot his name wrong there.
Um, Keith,
Keith Nichols, that was it. Yeah.
Keith.
So he talks about it, doesn't he optimizes that in his older guys as well. So I can see kind of all sides of the argument, really. I tend to take it on an individual basis, but certainly thyroid is routinely monitored. And what I've seen actually in the UK, oddly, is we're getting a lot of men with thyroid dysfunction. Even if it's not profound dysfunction, that their T4 and or T3 are both pretty low, and I've seen that
Sure.
quite consistently. I don't know if it's environmental or what, but certainly seems something I'm seeing coming across more and more.
So when y'all treat thyroid, what is y'all's thresholds like? Y'all's laboratory thresholds versus what we have here? Because like here, it typically the TSH is up to 4.5. How does that compare to what y'all have over there?
Yeah, that's roughly similar here. Some labs will go up to 5, some will go up to 4.2. I tend to take the approach of if it's over 3, I'm starting to get suspicious that there's an issue, but also look at the actual hormones levels themselves and look at
Mhm.
antibodies as well.
Oh, for sure.
Yeah. So again, it's kind of like an individual basis. My TSH was hovering between 4 and 5 for best part of a year, and I pulled the trigger on NDT. Ended up starting that about 6 months ago, and that was a big change actually as well. Definitely noticed the improvement there. Brought my TSH to below 1, but actually just symptomatically felt better in myself. So yeah.
Physiologically, what did you feel from it? What kind of symptoms did you notice an improvement
Yeah,
in?
I felt just a naturally better mood and a little bit more in terms of energy. Yeah, because I started feeling a bit sluggish, even though I was on the TRT. Not sluggish, not compared to how I was with low T, but not as good. And nothing else had changed except my TSH had gradually crept up over the last about 4 or 5 years. So that was when I instigated it with my doctor, obviously. But yeah, it did definitely made a difference. Yeah.
So you said you routinely check antibodies. A lot of people, it never happens. Most providers you go to, all they look at is the TSH. So what is y'all's thyroid evaluation like?
Well, routinely what we check is TSH, T4, and T3. But we don't routinely check it. But what we'll do is I'll add it in if there's some indication of dysfunction. Now, ideally, because what you can see, it's almost like if there's dysfunction present, then obviously the antibodies will tell you a little bit more information about what's going on. But also, if people have positive antibodies, even though their thyroid looks reasonable at this moment in time, it's almost like potentially, I say it's like a future predictor of issues.
Sure.
And some might argue that if you've got positive antibodies, even if your thyroid function looks pretty reasonable, you can still suffer with issues because it basically disturbs how well that thyroid's able to work.
Do y'all do any other diagnostics along with it? Do y'all do like thyroglobulin antibodies, or some people also do like vitamin D with it, or
Yeah, it's very sort of each case dependent. It's sort of like if it's almost like you use the routine panel and then you adjudicate from there as to, like you said
yes,
about checking further from there. So I kind of have an eye, and when I review someone, I always go through kind of each individual labs with them, just to say, look,
excellent,
this looks nice and stable or nice and good, or this is a little bit off here. Even like lipid panels, like we do the basic lipid panels, so total LDL, HDL, triglycerides. But if they want a little bit more of an in-depth view, we might run the ApoB and
sure.
lipoprotein and that sort of thing. So it's individually because we always bear in mind the cost element to it as well, because these private tests are, people in the UK are obviously more used to using the NHS, which is all free at the point of care. So over here, you've got to be mindful of this idea that you can't just chuck out a million tests because it ends up racking up. Do you know what I mean?
That's an interesting segue. How was it going from being more into like a massive, NHS type system to now matriculating to an individual private pay system? What's that like over in the UK?
For me, as the doctor, you mean, sort of changing over?
Yeah, yeah. What's
Yeah,
that been like, as
it's
a
awesome.
clinician and all that?
It's awesome. Yeah, yeah, yeah. It's brilliant. It's amazing. Yeah, I really like it. I like the independence that it gives you. And I like the way that you can basically just allows you to make decisions based on what you think's best, and as in what you think's best for the patient, rather than having to, listen to people above who aren't necessarily as well versed in these things as well. So I don't know, it just gives you that sense of independence in terms of you manage your own time as well. But it gives you more time with patients. Like, for example, when I was a GP, my appointments were 10-minute slots. So it wasn't
That's
unusual.
horrible.
Yeah, yeah. It wasn't unusual for me to see sort of 40 or at least 35 patients a day. Whereas now, my new patients are like an hour. My review
Awesome.
patients are a half an hour. But, even those new will sometimes run over, because you know what it's like when you're going through bloods and, potential treatment and everything like that. And sometimes they'll come back for a second initial appointment. So I just like having that decision making myself and managing my own time, but also giving people time, because I couldn't go back to a 10-minute model.
No,
It just would clash with how I want to do things, really. Yeah.
I've been there too, man. You just got to turn them in, turn them out. It's like
Yeah.
chronic disease management, COPD, diabetes, chronic disease, heart failure, and you get 10, 15 minutes. It's
Yeah.
not doing them any service whatsoever.
Yeah. And this is how people end up on 10 medications, because it's kind
Sure.
of like, if you've got 10 minutes, then you are literally against a clock to find a solution. And
Hmm.
sometimes that solution can be prescription. It's like the prescription ends the consultation. It's like, right, this will fix this. And in reality, how many times does a pill fix the underlying issue? Well, it might be provide a plaster, but it's not getting to the root cause of the issue, which, I like root cause
Yeah.
analysis. Let's see what's going on. And often it's not a 5-10 minute conversation. It's you've got to delve.
Yeah, yeah. Do you think more providers are going to start going the private route in the UK? Is that more of a newer type thing that's over there?
I think a little bit, yeah. I mean, particularly in the, like, for London, for example, there's more private clinics in London, just because it's a massive population, and there's maybe more financial freedom in London to go down that route. But I think there is potentially been more of a development in the private sector, particularly in TRT. I think because TRT's become such a big deal in America, and then people in the UK have seen people like Joe Rogan talking about it, and famous
Sure.
people talking about TRT. It's spiked their interest, and so there has been a development of more of a private sector in terms of TRT, because the NHS options or offering of TRT is quite limited. So I think that's developing for sure. But there has been a little bit more in the world of just, even preventative medicine, holistic medicine, all of these elements. I think it probably is going to grow over the next decade or so.
So if you had to go through the insurance model again as a TRT patient, tell them why the insurance model, isn't the ideal way.
Yeah, well, number one is access. So,
Sure.
for example, if you got referred to see an endocrinologist or a urologist over in the UK for potential TRT, one, your levels have to be extremely low, or by what we would consider to be extremely low. So, outside of the normal range, often that's below 200. Um, and then the waiting time to be referred on the NHS can be up to like a year to be seen.
Oh man.
Yeah, it's not great. But then the options even for treatment, like, they tend to use Nebido, which is the really long acting ester. So it's every 10 weeks. or 12 weeks even. So it's 1,000 milligrams every 10 to 12, 8 to 12 weeks commonly. Most commonly, it's every 10 weeks. Or the gels. Rarely they might use Sustanon, which is that blend, every 2 or 3 weeks. But in general, it's just kind of like, it's hard to get treatment, and the treatment, what I say to guys, it's hard to get treatment, but the treatment options aren't, in my opinion, the best out there. They don't provide a steady state. They don't provide, decent levels of testosterone. And so you're not going to often see symptom resolution, really.
Sure. That's kind of how it is over here too. You get punted around, you get referred to specialists, go back to your PCP, get 3 or 4 treatments of Clomid, and then, yeah, well, it didn't work. That's,
Mm.
it's wasting 2, 3 years of your life. So, I mean, it sounds
Yeah.
like that's kind of how it is over there as well.
Yeah, we have a few guys transferred, and it's kind of within weeks they can feel that difference, which is quite
Yeah.
nice to see. But it is, I mean, the weird thing is you can envisage a situation where if you wanted to use something like Nebido, you could use it if you just, well, it wouldn't be ideal, but you just split the dose up like we do with Cypionate. It's
Yeah.
kind of, if you did Nebido, maybe split it into 2 injections a week or even weekly, it would work much more nicely than this 10-week bolus dose. But hey,
But
it's what we
hey,
get
they're not
told
going
to
to,
do.
they ain't going to do that, man. And the
Yeah,
insurance
yeah,
ain't going to cover it
exactly.
either. They only cover
Yeah,
it for exactly what the indication is, which is, every 10 weeks.
yeah, true, true.
Right on, Dr. Max. Right on. Before we bounce, can you tell us a little bit more, or you got any closing words for us?
Not really. It's been no more to add to that, but it's been a pleasure to come on. I enjoy watching your channel on a regular basis.
Oh, thank
It's
you.
any stuff. Yeah. I would just add that I think a lot of my answers always sound the same because it's all about that individual. I'd really liked when you
Absolutely.
were talking to Jordan before, and he was saying about how um, I think it's an error for us to pretend to know more than we do, in the sense of we don't understand the intricate details of how some of this stuff works, which is why symptoms and sort of individual evaluation is so significant when it comes to particularly hormones, because like we said, is so much of this is intracrine, so it's going on within the cells. So
Hmm.
we can't always rely on lab levels. Um, so I think a lot of it comes down to that individual assessment and approach and just taking time to it. And like a little bit of what Jordan was saying was kind of like, we'll try a little bit more or we'll try a little bit less, because it's just working out what works for that individual. And I like that approach because I don't like to, because a lot of problems with medicine, you probably found this with doctors and things, is we've all got an ego, but I think the idea is what I try
Oh
and
yeah,
do is avoid implying that I know every single thing out there, because I don't at the end of the day. And so I think you've got to try and remove your ego to an extent and accept that a lot of this is based on the individual, and there is a degree of trial and error, based on experience and based on what we think might work. But at the end of the day, that might not work for the next guy you see. So there's always got to be that individual variation there.
absolutely, man. Absolutely. Well, Dr. Max, how can people get a hold of you?
AlphaGenix.co.uk. I think, or there's Insta, I think it's at AlphaGenix, and I think there's probably a Facebook page for AlphaGenix, or I'm at Max Your T on Instagram. My wife
That's
came
an
up
awesome
with it.
name. Oh
Yeah,
yeah,
I like
she
that.
did a damn
Yeah.
good job, dude.
Yeah. I'm quite IT illiterate, so she used to do all my Instagram and everything like that. She's a lot more of an IT whiz than me. Yeah.
That's awesome, man. Awesome. Well, we appreciate it, man. And thanks for sharing your knowledge and your time with us.
Oh, pleasure. Take it
All
easy.
right.
Cheers.
Thanks. Thank you, my man. Appreciate it.